go on to our next speaker, Dr. VANASHREE NAIR, who is a consultant cataract and anterior segment from Giridhar Eye Institute at Edapalli and Cochin. And she's another amazing surgeon, not just a surgeon, a person who can sing us and keep us enthralled in the 3 hours as against the amount of videos which you're going to see. So, but having said that, let's look at her interesting case. On to you, Dr. VANASHREE.
Thank you, ma'am. Thank you for giving me this opportunity to present in the ARC meet today. And I'll start my video now. So I'm talking about intermittent cataracts from polar cataracts. Let's move to these dense intermittent cataracts. So we all know that when we first take the nick, and if there's no fluid egressing out, then we know that the lens fibers are very tense. So my plan usually is to go with a double rhexis. I make a very small rhexis first, and then I decompress the cortical fibers from multiple directions using a small cannula. And as we can see here, I was successfully able to do that. And I went ahead with my micro-rhexis forceps to enlarge the rhexis. But here I could go ahead and make only a small another opening. So I went and took a nick with the scissors and slowly enlarged the rhexis using the grasp and regrasp technique. And here it is important that we keep an eye on the direction of the rhexis margin, because at this point I cannot proceed ahead, as we can see. So I changed my hand and went in with my right hand to take a better grasp at the edge of the capsular rhexis. And at this point, I realized that the viscoelastic was less in the anterior chamber. So I refilled the anterior chamber with viscoelastic and again went in with my left hand and completed the rhexis. Now, sometimes what happens, we have a situation where there is an intermittent cataract along with a relatively smaller pupil. So here, as I went ahead with my second rhexis, I was trying to take a grasp. I realized that the rhexis margin had already gone beyond the pupillary margin. And I changed the direction with my other hand and tried to continue the rhexis. But at this point, what I realized was the grasp over the rhexis edge was not good. I was not able to hold the rhexis margin. So I had a feeling that probably the rhexis had extended to the periphery. So here it was important to visualize. So I went in with my Kruglin's hook and lifted the pupillary edge to view. Now, to my good luck, it had not extended to the periphery, and using a bimanual technique, I could, under visualization, complete the rhexis using the micro-rhexis forceps. Now, in this particular case, what I wanted to highlight was sometimes the anterior capsule is very, very fragile. And here, as I made my primary small rhexis and I went and tried to decompress the fibers from all the directions, I usually go from 3 directions and try to decompress as much as possible. But in my enthusiasm to decompress, what happened was the cannula touched the anterior capsule and I had an extension towards the main port. Now I went in, put in a lot of viscoelastic to flatten the capsule and took 2 nicks to release the pressure, and so that the rhexis doesn't extend to the periphery. And as I was trying to complete the rhexis, what I realized was the anterior capsule was very, very fragile. And instead of having a good rhexis, what I had was a piecemeal breakage of the capsular rhexis here. So I completed the rhexis, and because it was, as I went ahead to the phaco, it was a soft cortical type of mature cataract. So nucleotomy was not very difficult. I could go with direct chop and slowly eat up the nucleus. I knew that the rhexis was weak right under my phaco probe, and I had to be very careful so that the anterior chamber does not collapse. Slowly, I went ahead and ate up the nuclear fragments. And at a point, I was afraid that the bag may collapse and the PC may come more towards the phaco probe. So in between, what I did was I injected more of viscoelastic without removing my main phaco probe, and went ahead with the nucleotomy. Till around about the small little fragments were remaining, I went in a little slowly so that the chamber doesn't collapse. And to my good luck, the rhexis, which was weak at one point, did not extend beyond the zonules. And before, the important pearl over here is to inject viscoelastic before coming out so that the bag doesn't collapse. And the cortex removal should always be away from the point where your rhexis margin is not intact. remove the cortex carefully, be very gentle and careful at the point where the rexus margin has run off. And the plan over here was to inject a single piece hydrophobic IOL, which I could slowly inject and rotate and keep the haptics away from the point where the rexus had extended. And after the wash of the viscoelastic, I realized that there was no further extension and the IOL was stable. So I had saved the day for the patient.
Wonderful video and different situations. So very well demonstrated how you tried to regrasp the rexus and how you did it. And it was a very smooth thing. The only question which I have is the cannula which you use to decompress the bag, so especially if there is a little partially open anterior capsule, I felt that you could have used a smaller gauge cannula because that could itself cause extension of the rexus because and the stability of the anterior chamber could be challenging.
Right. That was a learning point I learned, that I shouldn't be too over enthusiastic in decompressing with the same hydrocannula. Should have refilled the anterior chamber probably.
Yeah. And Harshul, you have anything to add? Yes.
Yes. I think, ma'am, that's a wonderful technique of double rexus, especially in intumescent cataract. I also use the same technique for 1 decade, and it works wonderful in these cataracts because the central area is very flat where you can easily make a small opening. I try to make very small opening of 2 millimeters, not more than that, and decompress with 27 gauge cannula and then make a second rexus. So it works wonderfully. And the second case which you showed, Dr. VANASHREE, was wonderful to visualize where the leading edge of the anterior capsular rexus is and not to go blindly. So that's a wonderful idea and very nice.
Dr. Gaurav, would you be able to tell us what are the pearls we should take to avoid an irregular rexus or a larger rexus in these intumescent cataracts?
I think she showed quite well, and one of the pearls was already there, but I would also use a soft shell kind of a thing, or maybe, I might have just missed that bit, but I love to use viscoat over here because not only does it give you that stability, but also in the area like where you had a runoff, I would have just gone back and put viscoat. It tends to push the pupil away and you can visualize better sometimes. And you can do a Bryan-Little's maneuver to kind of bring it back. I love to do the Bryan-Little's maneuver. It really helps. And sometimes if viscoat is not enough to move the pupil away, I would use a wide tip spatula. Just like you use the Kuglin soak, I would use a wide tip spatula sometimes and gives you visualization. So either of these things. And in a very rare situation, I've even used an iris hook. It was right next to my main port incision. So I used an iris hook because there was no other way and it was counterintuitive. But other than that, I think Dr. Chitra wanted me to talk about maybe decompressing the lens. I normally go with a 26 gauge or a 30 gauge needle onto a 1 ml syringe, and I use a separate port. I don't go through either the main port or the side port. I put good enough viscoelastic, enter at the limbus with a paracentesis port, and then go and aspirate and decompress. So I mean, there's so many ways to do it, and I'm sure Dr. Mohan Rajan is itching to tell us something about his techniques.
No, not the moment. I would take your question later on. No puncture rexus at this point of time. I would want to ask another question. I had an opportunity to watch in an earlier video session of, instead of making a linear incision, a C-shaped incision was being created. Expert panel have any thought on that? If by directing the incision away instead of taking it linearly, would you be able to avoid a rexus runoff?
I don't think so.
I think it's a very relevant point, Chitra. I mean, in the sense that the rexus never runs circumferentially. It only runs to the periphery. Yeah. So if it's in your initial incision, it's slightly arcuate, the tendency for the rexus to run off is much less. So instead of, if you make a straight cut, then the rexus to get an Argentinian flag sign for it to extend on either side is a little more. But if your initial neck is a little C-shaped, then maybe arcuate, then the tendency is less. Not that it cannot happen. The slight, I almost agree with everything that Gaurav says, but then I slightly differ on the usage of the viscoelastic. One of the rare situations where I want to use Helon is this kind of situation where I want a flat anterior capsule. And I feel that more than viscoat, which coats the endothelium very well, but as far as creating space and keeping the anterior capsule flat is concerned, is less effective than Helon. It's one of the situations where I might do an initial fill with Helon, chondroitin sulfate combination, and then push in a little bit of Helon to flatten the anterior chamber and create a flat anterior capsule, which helps me to create a rhexis in these situations, apart from all the other points that were discussed.
Totally agree, sir. Totally agree on that. I mean, I also use a soft shell to begin with. I mean, Helon right over the capsule, and this thing to coat the endothelium, and then towards the surgery, like intraoperatively, if I have anything, then I like to somehow use Viscot because it retains much better. Than
Yes, 100%.
Because the Helon just flows out as a bolus.
Comes out in a bolus, yes.
Can I add a point?
Yes.
So honestly, that's a very nice surgery which I've seen right now. Like the second one where when you're removing your instrument, we could see that rhexis was running to the periphery. So in that kind of situation, like most of the times what I do is I give preference to debulking the capsular bag. So if you debulk the capsular bag, the risk of the rhexis runout will be minimized. So I give precedence to debulking than for management of the anti-capsule. So if you do that, I think the chance of rhexis going to the periphery will be very low.
Dr. Arun, do you want to add anything? That was a valid point, Dr. Ramakrishnan.
The only thing, everything has been spoken about, but for the new people, what I'll say is you need to balance the intralenticular pressure all the time to achieve a good rhexis. So soft shell technique has been talked about. So basically you need to balance your intralenticular pressure and your rhexis will not run away.
Yes. Dr. Sonu Goyal, you have anything to add? Shall we go on to the next speaker?
I just wanted to ask a question.
Yes.
Puncturing the anterior capsule with the 26 gauge needle is very helpful. We all know about it. Does intraoperative mannitol or preoperative mannitol also help?
I give for all patients.
Yes.
All my patients are done under perioperative mannitol.
No, I wouldn't do that for all my
I don't give
all
patients.
I'm talking about intimacy.
Intimacy cataracts.
I don't give.
I'm talking about intimacy cataracts, not all patients. We are talking about intimacy cataracts.
Yes.
How does it help?
How will it reduce the intralenticular pressure?
Please understand there are 4 components in the type 1. We are talking about type 1 intimacy cataract. What she showed was first case was type 2. The type 1 intimacy cataract, well, as soon as you touch, it will go. Okay, in the type 1 intimacy cataract, there are 4 components. There is pressure underneath the anterior capsule. The nucleus is bulky. There is pressure in front of the posterior capsule. There is also positive vitreous pressure. 4 components we have to take care. That is why my puncture-rhexis works 100% of the time. Yeah, because it decompresses, it punches the anterior capsule, it pushes, because you are giving a phaco power, it debulks the nucleus, pushes the nucleus back, and also it decompresses the posterior compartment also within a millisecond. That is what happens because it's a bigger bore. If you use 26 gauge, 27 gauge, okay, it may work about 50-60% of the time. But if you want something to work 100%, it's either puncture-rhexis or femtorrhexis.
Okay, I wanted to discuss puncture-rhexis definitely in this webinar. I had kept it for another Dr. Rahul Shukla's case. But anyway, we got the information.
Sorry.